So what I'm going to do today is to give you a brief overview, particularly on the recent update of biomarkers. And these are biomarkers that have pretty clear clinical implication, particularly for treatment selection for lung cancer patients. Okay, so we all know that cancer is actually a genomic disease. And so cancer genomics definitely have a very clear clinical application, particularly for disease diagnosis, as well as for treatment selection. And as mentioned by Dr. Tsai, these biomarkers can also be used for prognosis as well as for disease monitoring. And there are many different types of genetic alteration that are significant in cancer genome. So in addition to point mutation that we are very familiar with, amplification and deletion are also frequently found in the cancer. And definitely translocation, gene fusion, present the main driver and also drug targets for treatment selection. What we gradually learn is that although most of the driving mutations are actually initially for example, small insertion deletion or point mutation, but once you begin to treat the patient, then the patient's tumor can quickly escape through taking different genetic alteration or taking alteration on different genes or even in different pathways. So all of this information has to also be taken into consideration before we can make a good judgment on how to treat the patient. And so it is worthwhile to look at all of the potential markers as well as well-validated markers and see how we can integrate all of this information for treatment selection. And so when we talked about lung cancer, we know that histological classification of lung cancer is that we typically have more non-small cell lung cancer and compared to small cell lung cancer. And in the non-small cell lung cancer, also we have dominance of adenocarcinoma versus squamous cell carcinoma. So today, what I'm going to do is focus on the biomarker for particularly adenocarcinoma, since this is a cancer type that currently it has a very clear driver path, and it also have particularly non-overlapping driving mutation compared to, for example, squamous cell carcinoma. We can see that in adenocarcinoma, patient typically will have a dominant driving pathway. And so this allows for the selection, at least for the first treatment. But for squamous cell carcinoma, you do see a lot of mutation, and actually this has something to do with the etiology. So the treatment selection or treatment guidance for squamous cell carcinoma is not as clear defined. So for the next few minutes, what I'm going to focus is on lung adenocarcinoma. And our current idea and also the recent biomarkers for the management of adenocarcinoma. And here I'm going to kind of give the presentation in what we call a putative or potential molecular diagnostic algorithm or guidance for non-small cell lung cancer. So since we know that NCCN guidelines also provide algorithm for treatment, for molecular test and treatment guidance. So here I'm gonna present this in the same way. And what I will highlight here in different colors, all those markers that are shown in deep blue. These are already approved companion diagnostic. And then there are second level of markers. These have not been shown with a randomized trial or have not been approved as a companion diagnostic by FDA, but it's actually already in the NCCN guideline. So these are second group of biomarkers. The third group of biomarker what we call potentially clinically actionable. So these have some clinical evidence, but is not strong and has not been in the guideline. But these are the new emerging markers. And these new emerging markers are important because of the availability of drugs that are targeting all of these mutations, or they actually provide important clinical implication. For example, STK11 mutation confer resistance to immunotherapy regardless of the cancer type, regardless of the other tumor markers. So here, we can look at this, and then I'm gonna kind of walk through this table and give you some information. So let's look at the first biomarker, and we can look at the non-small cell lung cancer signaling pathway. Then we can see that, of course, in this group of patients, the most dominant mutation will be the EGFR sensitizing mutation. And we already know either for LFIAR mutation or exon 19 deletion, you have many already approved first generation TKI that provide very good efficacy. So this is very well documented marker. But what happened when this patient been put on first generation or second generation drugs, and they begin to develop resistance or their disease begin to progress? What are we gonna do? And what could be the biomarker that can offer the treatment option for the next step? If we look at the drug resistant mechanism for EGFR first and second generation TKI, in those patients who originally has EGFR sensitizing mutation, then this is actually the distribution. And so if we look at the distribution, it's very easily that we can see that at least about half of the patient develop resistance by developing T790M mutation. So this will be the main resistant mechanism. The other mechanism, the remaining mechanism, again, you can see that here, some will develop bypass mutation. Others will actually also use small cell lung cancer or transform into small cell lung cancer. So here, at least about 85 to 90, 80 to 85% of patients whose resistant mechanism can be identified. And most of these resistant mechanisms already have markers that we have the option. So for example, if the patient is T790M mutation negative, then they could be MET amplification, could be HER2, could be the remaining pathway. So here, this is a distribution. And we already know that if these are the treatment options that we will show later. But for the patient that harbor MET amplification, and they originally have received first generation and second generation TKI, and they're T790M negative. Then based on this clinical trial study, actually third generation TKI data and plus MET inhibitor seem to be a very good selection. So you can see that the patient actually show pretty good response. So here, oops. We can see that, for example, this group of patients, you can add the MET inhibitor. And of course, we know that if the patient develops T790M mutation, then you already have a pretty good third generation TKI that can effectively manage the T790M mutation. But we also know that patients with T790M mutation, once been put onto the third generation TKI, also develop resistance. So we need to know what kind of resistant mechanism contribute to the treatment resistance, and then develop appropriate management. So here, this particular slide shows that drug resistant mechanism for third generation TKI, actually these are, we can look at this data and see that a lot of patients actually have loss of T790M. And then, so for those patients who lost T790M mutation, they're associated with a short-term progression-free survival. So this is very easy to see. But for those for those patients who actually acquired resistant mutation, so this patient actually will have both T790M mutation as well as a new mutation, the secondary resistant mutation, and this typically occur at C797 position. So these patients tend to retain their T790M. And another group of patients actually also develop additional mechanism. So for example, in addition to C797 mutation, they can also acquire resistance by utilizing bypass pathways. So based on this information, here is a summary. So for those patients who develop resistance to a third generation TKI, about 21% actually acquire EGFR mutation again. So this is the resistant mutation on C797. MET amplification actually also account for about 20% resistant mechanism, and then followed by cell cycle gene alteration. And the remaining, actually, the remaining pathways are still those dominant and driving pathway in the non-small cell lung cancer, so including HER2 amplification, PIK3 alteration, and other oncogenic fusion, and finally BRAF mutation. So here, most of this, particularly BRAF mutation and also for oncogenic fusion, once you can identify the appropriate resistant mechanism, then it will have a pretty good handling on managing these patients. So if we look at this EGFR, initially patient with EGFR sensitizing mutation, whether they develop resistance because of T790M mutation or not, we have pretty good biomarker, and based on this biomarker, we can also develop treatment solution. But this only help about 50% of patients. What about those patients who actually receive the driver, receive prior resistance, prior treatment with third generation TKI? For those who develop resistance because of MET amplification, again, this data shows that this patient the MET amplification in this patient can be managed by adding the MET inhibitor. And as Dr. Tsai mentioned before, if you see patients with MET amplification before the treatment, before any treatment, those MET amplification perhaps do not have very significant clinical implication. But if you observe MET amplification after TKI treatment, even though those amplification do not give you like 8 copies, 10 copies, it's not extremely high amplification. Those patients tend to respond quite well. And so here, even though when we set the threshold for amplification, typically we will only report amplification if the patient has more than 8 copies amplification for most of the genes. But for MET amplification, the threshold need to be set lower because of this this reason. And so we pretty much take care of all of the patients who has EGFR sensitizing mutation. Then the second pathway and also pretty dominant pathway in non-small cell lung cancer is ARC fusion. And ARC fusion actually accounts for only about 3 to 5% patient. And we already have amples of ARC inhibitor. But what about when the patient develops resistance? typically the patient respond to these inhibitors because they actually display ALK fusion. But when they develop resistance, typical resistance actually occur in the ALK kinase domain. So a patient develop alteration either by producing resistant mutant or by ALK amplification. So again, you use the same pathway, and you just drive this pathway by bypassing the drug inhibition. And then, of course, there are other bypass pathway that can be used to bypass ALK inhibition. So here, the determination of ALK mutation instead of ALK fusion is more important when talking about treatment option following the first ALK inhibitor treatment, because here we need to identify exactly which mutation is present after the treatment, and then based on the mutation pattern to decide which drug can be used to treat the patient. So the major pathway or the major mechanism is actually secondary mutation. And as we mentioned that there are already 5 ALK inhibitors, and then the last one is actually was not originally identified or developed as ALK inhibitor, has been in the market. And here is the IC50, or the inhibition potential or activity of these 6 different inhibitors on wild type ALK gene, also on all of these different mutations. And you can see that, for example, this actually shows why Dr. Tsai prefer this drug, because you can see that this drug has some pretty low IC50 against a majority of resistant mutant of ALK variant. So here, it either developed the display IC50 between below 50 nanomolar or somewhere between 50 to 200. So compared to other ALK inhibitor, this is by far more potent, and also it will be more effective compared to other ALK inhibitor. And so if you have any choice, and if the patient can be enrolled into clinical trial or any study of some sort, then definitely this will be the best selection. But of course, there's also some particular mutation, some particular variant. The patient is better off using a specific inhibitor. So this is a very important data that showing you need to understand and carefully characterize individual patients' resistant profile down to the variant level. Then based on this information to select the next ALK inhibitor for the patient. And of course, you won't be able to memorize all of this. So this is why we actually have to have a group of scientists dedicated to take all of this information into consideration when when we map the genetic alteration, particular specific variant, to all useful drug for clinicians. So you don't have to look into this table and try to figure out which drug will offer activity to individual resistance. So here, this is a clinical trial that actually evaluate efficacy of ALK TKI on different ALK resistant mutant, and pretty much actually follow the previous table. So now we kind of take care of the second group. Now the third group will be the patient who are EGFR and ALK wild type. And so those patients who are EGFR ALK wild type, there are drugs that are already approved for example, BRAF, for RAS1, for NTRK fusion. And also, there are another group of patients who may harbor a mutation in EGFR exon 20 who may have MET amplification. But this MET amplification, and particularly MET exon 14 skipping, is actually a very important pathway. So we'll go down this list one by one. And then finally, in addition to all of the targeted therapy that work on specific drug target or genetic alteration in the patient's tumor, there are also this biomarker called tumor mutational burden. This is a marker for immunotherapy. And we can also think about how to utilize tumor mutation burden. But if we look at the distribution, then this is actually the distribution of all these different mechanisms for the remaining patient population. And as I mentioned before, these are all mutations or genetic alteration that have already have corresponding treatment or approved by US FDA. So these are pretty straightforward. But what about when this patient develop resistance? For example, patient with RAS1 fusion develop resistance to crizotinib, or NTRK patient who develop resistance to laltretinib. And here is the distribution of patient who develop resistance to crizotinib. And you can see that majority of the resistance again occur at the RAS1 kinase domain. And it's actually the dominant resistance will be in the G2032R, and then pretty much very close region. So here we know that these are the resistant mechanism. And there actually data have already shown that other inhibitors can overcome the resistant mutant with G2032R. So again, with this information, we know that even though there's no clinical trial data, but this data already provides some hint what will be the next treatment option for this patient. And similarly, for those patients who develop resistance to first generation NTRK inhibitor, actually Laxo already developed the second generation Laxo NTRK inhibitor called Laxo 195. And so depending on the genetic alteration, again, if we look at the resistant mechanism, most of the resistant mechanism is on the kinase domain. But depending on the kinase, the specific mutation region, this patient can actually be dealt with different inhibitor. So this, again, offers some solution or potential option for patient once put on NTRK inhibitor and develop resistance. So far, when we look at all of these TKI-based treatment, you can see that majority of resistant mechanism occur at the kinase, at the drug target kinase domain. So you have to clearly identify the exact mutation and then decide what would be the better treatment option. So those are all of the markers that has FDA approved drug. But we also have a group of patients who are neither EGFR or mutation, also don't have RAS1 and NTRK or BRAF mutation. So if we look at this patient, then we found that they're either EGFR mutation, but in the resistant region, or MET amplification for various reasons. So we can go down this list one by one. For EGFR exon 20 insertion, before, we know that this group of patients, they're quite resistant to first generation and second generation TKI, except we know that one of the particular insertion is actually responsive. So even though when we talked about exon 20 insertion, we should not include all exon 20 insertion. We still have to specifically determine which exon 20 insertion and then determine the treatment strategy. The other thing is that when the patient doesn't have the particular exon 20 insertion, if the patient has other exon 20 insertion or mutation, then another drug is already shown pretty good activity in exon 20 insertion. So we can also expect to see this drug approved for specific exon 20 insertion. Here I would like to mention another mechanism of that drive the tumor, which is exon 14, MET exon 14 skipping. MET exon 14 skipping actually convert this gene into this pathway into constitutive active pathway, and so this this is actually quite abundant, more abundant than we imagined. But how do you detect exon 14 skipping? Typically, exon 14 skipping occur because there are mutation at the splicing site. But you can either use DNA-based or RNA-based detection. When you use DNA-based detection, you need to identify specific mutation near the exon, intron-exon junction. Unfortunately, the distribution of exon 14 genetic alteration in the intron exon junction are quite diverse. So even though we can try to cover as much as possible, but you will still miss this mutation. But all of this mutation on the near the splicing junction, the end result is to create an exon 14 skipping product. So you will see exon 13 and exon 15 spliced together. So in this case, if you use an RNA-based analysis, specifically detect the exon 13 and exon 15 product, it will have much better sensitivity. So here we're talking about for detecting exon 14 skipping. It's much better to use DNA plus RNA-based detection method, so that we can cover all of the exon 14 skipping product. And this is the main reason, because the mutation actually distribute and are very diverse. So this is why when we look at, for example, our service in the egg drug, exon 4 MET is detected and sequenced at the DNA level. But in the fusion assay, we actually also look at the exon 14 skipping by looking at the fusion product. Well, we don't call it fusion product, but it's actually exon 14 splice transcript. So combining these two data will actually offer a much better and much more comprehensive idea to know and to detect exon 14 skipping. And of course, exon 14 skipping have already shown pretty good sensitivity to a lot of drugs. So if you can sensitively identify this biomarker, exon 14 skipping, then you can provide the patient with a lot of treatment option. And also, in addition to MET amplification, there's also a group of patients in the lung cancer who either show mutational amplification in HER2 pathway. And so for the patient who develop HER2 pathway alteration, currently I think the best data that we see is that TDM1. So this is an antigen drug conjugate that actually offer pretty good clinical efficacy for patient. And this is actually not a drug currently approved for lung cancer, but initial clinical trial data seem to show pretty promising result. And finally, before, most of the fusion we see are OCK fusion or ROS1 fusion, and for RET fusion, previously we don't have really good drug to treat patients with RET fusion, but we now actually see a pretty good efficacy, either use BLU 667 or Luxor 292. And so these are all studies done in non-small cell lung cancer sample. And so we can expect to see some of these drugs will be quickly approved. And so the ability to detect RET fusion is also important for selecting treatment. But again, we can also expect once the patient is put on the treatment, sooner or later they will develop resistance, and most likely resistant will also be on the RET kinase domain. And so similarly, we need to identify those resistant mutants at specific region. So we cover all of those targeted therapy. But we also know that one of the most exciting theme that comes to cancer therapy in the recent years is the availability of immunotherapy. And although immunotherapy is very exciting, but we also know that it only exhibits efficacy in a subset of patients. And so this is why we actually need to conduct, for example, PD-L1 staining before we subject the patient to immunotherapy treatment. But one thing is pretty clear, that for those patients with non-small cell lung cancer, if they have clear oncogenic driver, their response rate tend to be very low compared to those patients without oncogenic driver. So again, this is the possibility that if you see the patient who has oncogenic driver, then it probably will automatically or will be a pretty good exclusion criteria for the patient to select immunotherapy. So first thing is that we can probably use this main driver to exclude patient. The second thing is that, what about those patients who did not show high PD-L1 staining, who also did not show oncogenic driver? What would be potential biomarkers? And so we know that recent studies have shown that tumor that has more mutation, so those patients who has high tumor mutation burden tend to have better chance to respond to checkpoint inhibitor. So, and this is the data from CheckMate 227, although I think they did not show the data in this ASCO, and they kind of pushed back their effort on TMB. But nonetheless, this data actually show that tumor mutational burden could be an additional biomarker for immunotherapy. And in addition to Nivo and Ipi, other companies also looking into tumor mutation burden as a biomarker. But later on, we will come back to this point. Tumor mutation burden is a positive biomarker for immunotherapy. Then after all of this biomarker, here are what we consider emerging or potential biomarkers. So this includes a lot of mutations that are frequently detected, but we before do not know their clinical significance. So if we look at the distribution or the population frequency of patients with this mutation, this is the distribution. And one of the important biomarker is actually the tumor suppressor CDKN2A. This gene is actually frequently mutated or deleted in lung cancer. And before, there's no treatment option. But now we know that through the TOPPER program, they actually show that those patients who has CDKN2A loss or mutation in non-small cell lung cancer tend to have better response to CDK4/6 inhibitor. So this is very different from those previous markers that we see. For those previous markers, we typically look at the drug target. Here we are looking at a loss of that suppressor that actually activate this pathway. So in addition to just looking at the drug target, we also need to look at the entire pathway, upstream and downstream. So mutation in CDKN2A actually activate in the absence of RB1 mutation, actually activates cell cycle pathway and confer sensitivity to CDK4/6 inhibitor. So here, for this particular biomarker, we need to look at not just CDKN2A. We also need to look at whether this particular patient has any mutation on RB1. If the patient also lost RB1, or if the patient has RB1 alteration co-occur with CDKN2A, then this patient will not respond to to CDK4/6 inhibitor. So here, it's not just one biomarker. We need to look at the status of two biomarkers at the same time. And of course, this is actually, I think, one of the most exciting biomarker that we can see for non-small cell lung cancer. KRAS is a mutation, is actually a very important biomarker, but before there's no actionable solution. So we typically would just kind of ignore this pathway and this biomarker. But now we know that AMG 510 is actually show activity in non-small cell lung cancer patient with this particular mutation. So here, this mutation is G12C. So we're not looking at the mutation. We are not looking at G12 mutation. We need to have a very specific mutation, G12C, because this is the position that allows AMG 510 to act. And so we still don't know the population frequency of G12C in Asian population. We hope that to actually calculate and see what kind of population will actually benefit from this treatment. And then another potential drug target is actually NRG1. But this is not the drug target. This is just the fusion actually activate EGFR, actually HER3 pathway. So with this activation, there's also another drug that can be used to treat, to deal with this mutation. So NRG1 fusion will be additional biomarker to test. Now, before we always look at the sensitivity markers, but the last few markers that I would like to emphasize is resistant marker. And the most important resistant marker is that particular in the last year is STK11. STK11 is a very long tumor suppressor, frequently mutated in cancer, and also mutated at very high frequency in non-small cell lung cancer. And it was shown that patients with STK11 mutation would not respond to checkpoint inhibitor at all. And this resistance is not related to KRAS status. Here we can see that STK11 is frequently altered in non-small cell lung cancer. So here you see about 23% mutation. And it quite frequently co-occur with KEAP1 And these two mutations actually display completely lack of benefit, either by immunotherapy alone or even in the setting of immunotherapy plus chemo. So when we talked about selecting patient for immunotherapy, we look at PD-L1 staining, we look at tumor mutation burden, but we also need to look at whether this patient already have intrinsic resistant mechanism. So if the patient has mutation in this pathway, then even with a PD-L1 high staining or with high tumor mutation burden, this patient would not respond. So this is why, without current understanding of this mechanism, it is not enough to just know the patient's PD-L1 staining or tumor mutation count, but also content. And the last biomarker that I will mention is that in addition to those patients who would not respond to checkpoint inhibitor, there is a group of patients whose tumor will actually grow even faster when put on the treatment of immunotherapy. And these are the group of patients that we call hyperprogressive patients. And recent studies have confirmed that hyperprogression is a real phenomenon, and actually there are genetic alteration associated with this hyperprogressive disease. So for example, patient who has MDM2 amplification or patient who has EGFR mutation, they tend to display hyperprogressive response once put on immunotherapy. And so in this case, for this patient, treating patient with immunotherapy will cause more harm than providing benefit. So these are, again, need to be taken into consideration. So if we look at all of these potential actionable markers, then some of these will provide resistance markers, and then others will actually alert potential harmful outcome for immunotherapy. So these are what we consider a pretty good or at least comprehensive algorithm for molecular testing for treatment selection guideline for non-small cell lung cancer. So with this in mind, I have the last 3 slides to show that all of these markers need to be tested, but with what kind of panel you can have enough information is very important. So typically, most of the oncology panel or lung cancer panel are those very small panels. So for example, panel like ECDRUG that's specifically focusing on drug targets. And then, of course, you can use a larger panel like onco, which cover not just the drug target, but also additional resistant information. And you also have panel, typically very small panel that can be used to monitor patient's disease. And if we look at, for example, for this particular treatment selection algorithm, then there are a few markers that are highlighted in red. These markers are only, can only be detected using a large panel. So for example, tumor mutation burden, or for example, KEAP1 and STK11, or MDM2, MDM4 amplification. These are all important biomarkers, particularly exclusion biomarker for immunotherapy. So if the patient is seriously thinking about using immunotherapy, or if the patient develop resistance to immunotherapy, and he would like to understand the next treatment option, then I think the best bet or the best assay to go for will be a more comprehensive test so that you can understand whether the patient actually develop resistance by inactivating all these pathways. If we use ACT drugs, then this kind of panel is actually very useful for most of these targeted therapy, and even for a lot of guideline markers, except for TMB, and perhaps even for some potential actionable mutation. And finally, for disease monitor, because we typically monitor resistant mechanism and follow specific mutation. So ACT monitor or liquid type panel is useful for most of the FDA approved drugs. Typically, liquid biopsy cannot detect fusion with high sensitivity. So it will not provide positive marker. But liquid biopsy can detect resistance. So for example, ACT monitor will not be able to detect RAS1 fusion, will not be able to detect ALK fusion. But it can detect mutation on ALK kinase, mutation on RAS1. So it would not be useful as an initial diagnostic marker or diagnostic assay before treatment. But it will be very useful once the patient is put on the treatment and then begin to develop resistance by mutating the drug target itself. This, in this situation, typically you will see point mutation, which can be detected using liquid biopsy with high sensitivity. So, so this is my last slide. And thank you for listening.